Hi, hello everyone. My name is April, last name Wallace-Spriggs. I am a patient care coordinator that works for Hearing Aids Are Us Academy. Hearing Aids Are Us Academy is ran by a Mrs. Betty Bloom, my supervisor. And, excuse me, on today, Mrs. Betty Bloom gave me the instructions of going to a community setting such as a mall in the city of Chicago, and she actually asked me to go out and give information about the disorder atresia. Okay, some of the subject matter that would be covered are as follows. Is as follows, I should say. Okay, number one, she asked that I give a little background information on this disorder. She asked also that I give some audiometric testing that would be performed and or recommended. What audiometric findings would be anticipated with this disorder or associated with the disorder. What other medical tests may be ordered or associated with the disorder. What might those medical tests reveal? And what treatment would be recommended and why? So you all sit back and listen. We're going to give you some information, hopefully very informative information that can help you if it's a disorder basically that has impacted your family or yourself, your children. Hopefully you'll receive some very helpful information, and we would like to partner with you in terms of basically tackling any problems basically that you may have, and we'll see how we can accommodate you. Thank you. Okay. Oral atresia is a lack of a fully developed ear canal within the middle ear space and ear bones, excuse me, I'm sorry. Oral atresia is often accompanied by microtia, which is a congenital deformity of the outer ear, which simply means that the person was born with this disorder. Microtia and atresia may be unilateral, meaning that this is a disorder that has occurred in one ear, or it can be bilateral. It can occur in both ears. Surgical repair of congenital oral atresia attempts to restore natural hearing, to the ear by opening an ear canal, freeing the ear bones, ossicles, constructing a tympanic eardrum, lining the new bony ear canal with a very thin skin graft, and creating an opening, meatus, so to speak, in the skin-lined ear canal with tympanic membrane and ossicles that vibrate freely, allowing sound energy to be conducted efficiently to the inner ear. In selected patients, the chances of achieving normal or near normal hearing with surgery approach is 90 to 95%. Not all children are candidates for atresia surgery. Let's say that first and foremost. A child's candidacy, for this delicate operation lies in two important tests: the hearing test, audiogram, and the computed tomographic CT scans. I'm sorry, you all. The audiogram ensures that the child has normal inner ear cochlear function, and the CT scan allows me to see the development of the middle ear space and the ossicles. I judge a child's candidacy for inner ear structures. I used the grading scale originally published in 1992 by the mentor Dr. Robert Schroeder. The child's ear anatomy is graded on a 10-point scale. The higher the number, the better the normal or near normal hearing. An 8 out of 10 portends an 80% chance. A 9 out of 10 predicts a 90% chance. A recent analysis of our surgical hearing results actually shows that a child with a 7 or better has an 80 to 90% chance of achieving normal or near normal hearing. The timing of atresia repair depends on many factors: age of the patient, maturity of the patient, and type of outer ear reconstruction. For example, microtia repair. For details, the family has chosen to name a few. I generally do not recommend atresia repair, either in children with unilateral or bilateral atresia, until the child is old enough to cooperate with the post-operative care that is absolutely necessary to ensure an excellent result. 1 week after surgery, the child must sit still for me to remove the packing and clean the new ear canal in the office. 1 layer of dead skin that develops in the post-operative period, I have found that children ages 5 and older are old enough and mature enough to let me do the necessary post-operative care in the office. 7 to 9 years old who cannot sit still for me to clean the ear, but I cannot take a chance and jeopardize the successful surgery with poor or incomplete post-operative care. Children over 5 consistently will allow me to do what is necessary to ensure the best surgical outcome, by removing packing and cleaning and debriding the ear in the office. For the child not able to tolerate these office procedures, I must return the child to the operating room with the added risk of more general anesthesia. I see no physiological advantage to repairing unilateral or bilateral atresia any earlier than age 5. If the child has bilateral atresia, the bone conductor is worn until the child is ready for surgery. The magnificent thing about the auditory system is that both sides of the brain receive auditory information from both ears, and the auditory information that goes to the opposite side of the brain crosses the midline very early or soon in the neural auditory pathway from the ear to the brain. Unlike the eye, where if the brain does not receive input from one eye, a lazy eye or amblyopia, the eye is functionally blind. Both sides of the brain learn to receive and process auditory information from both ears. So as long as one ear is working well, either a normal ear in unilateral atresia cases or an ear with a bone conductor in bilateral cases, the auditory centers on both sides of the brain will develop normally. There is no advantage as far as the auditory centers of the brain are concerned in receiving auditory input from both ears as early in life as possible, as long as the brain is receiving auditory input from at least one ear. The advantages of binaural hearing, which is why we correct unilateral atresia cases, include better ability to hear when there's background noises, and we live in a very noisy world, and the ability to locate sound in space. We are currently testing our unilateral atresia patients with special audiological tests before and after atresia surgery to validate and reinforce this statement. This article was written or inspired by a Dr. Brad Kaser. And in reference to this article, his response was that he hopes that this site has been established to provide information about oral atresia and the potential for repair. And his hope was that it will assist you and potential other families in understanding the benefits and risk of atresia repair. If you have any questions or concern after visiting the site, you're encouraged to reach out to his practice. There was a listing of questions and answers basically that were provided, and I'm going to go through a few of these, and we're going to close out this information session for the public. One statement was that my child was born with microtia, and/or atresia in both ears. What now? Why aren't all children candidates for atresia surgery? At what age should I pursue the CT scan? At what age should I pursue hearing testing? What is the difference between atresia and stenosis? And I'll read one other question. What is the difference between conductive hearing loss and nerve type hearing loss? There were many other questions basically that were listed on this question and answer session, but I'll just cover the first five to six questions, okay? My child was born with a microtia, I'm so tongue-tied. My child was born with microtia and/or atresia in both ears. What now? For children born with bilateral microtia and atresia, the first step is a hearing test. Because we cannot put a newborn in a sound booth and ask if he or she can hear the tones or words, we have to do a special test called a brainstem auditory evoked response test, often called a BAER or ABR or auditory brainstem response test. Much like an EEG, this test measures the coordinated electrical activity response in the auditory nerve and brainstem. It relay centers when the ear is presented with a sound, usually a click or a tone. The most important part of this test is to measure the bone conduction thresholds. This means that the audiologist or tester places a microphone on the bone of the skull and delivers the signal through the bone to the inner ear. This test measures how well the inner ear receives the sound signal and converts it to an electrical signal. In most cases of atresia, the inner ear has developed normally and can convert sound to electrical energy that we can measure with the BAER test. Okay? I don't want to run out of time. Okay. Why aren't all children candidates for atresia? A child must have some development of the middle ear structures an air-containing space, the ear bone, hammer, anvil, and stirrup, and an open oval window into the inner ear. If the child has no space in the middle ear, the ear bones cannot vibrate and sound conduction will not be restored. If the oval window is closed, we have found only about 50% of children who have a drill out of the oval window will enjoy good hearing long term. If the all important facial nerves is in the way, surgery to open the ear canal would be too risky, and the child might suffer paralysis of that side of his or her face. Finally, the bone separating the brain from the ear may hang down too low and also be in the way for any attempt to open the ear canal. We would not want to risk brain injury in attempting to open the ear canal. At what age should I pursue the CT scan? Generally speaking, we do not recommend a CT scan until the age of 5 to 6, when the patient and family are beginning to consider the atresia surgery. C, at what age do you recommend atresia surgery? To my audience, you all please excuse me. I need my glasses, so I'm experiencing, a little bit of optimal discomfort here. So we'll just go over a couple of other questions for the sake of time, and I hope that today's session has been an extremely helpful, informative session for you. At what age should I pursue hearing testing? Hearing testing, BAER, should be done after birth and at least yearly thereafter. As the child gets older, sound-filled in a soundproof booth, testing will be better than BAER testing. And as the child gets older, still visual reinforced audiometry or testing of the individual's ears with air and bone conduction thresholds will be possible. For unilateral atresia, I recommend hearing testing yearly to ensure that the normal ear is working well. And for the sake of time, the time is getting away at this time. I do hope that the information that I have shared with you has been most useful to you, your family. Any other questions that you have, please feel free to reach out to our company. I'll be passing out some business cards and brochures and flyers in reference to the company, and we will not only share information with you in reference to atresia, we'll have other information basically that you or some of your family members may or may not have been aware of services that we offer. Okay, I'm going to turn this information session over to Mrs. Betty Blue, my wonderful supervisor. And these and all of the messages, this is going to be it. You all have a wonderful day. I've enjoyed talking with you. Have a great day.